Good afternoon. We want to call to order the Budget Subcommittee number 1 of Human Services. I want to thank all of you for coming today. It is good to see so many of you here, obviously concerning a very important item on the agenda. We want to get moving on this agenda as quickly as possible in order to conserve time and make sure that all those who desire to be heard are heard. I'd like to start by saying that all of you know, due to the amount of persons here probably wanting to testify, that we will probably have to limit our panelists to no more than 3 minutes each and our public comments to 1 minute, as you can see from the ones here in the audience. Our budget analyst, Nicole Vasquez, will be keeping time and will give signs to indicate how much time you have left. So we want to try to keep this as fair and efficient as possible, but at the same time give you an opportunity to hear, for us to hear all of the issues that you have, obviously will have identified. If you go over your allotted time, we'll have to be forced, unfortunately, to try to cut you off or to ensure that everyone else has a chance to speak to the agenda here. We know many of you have made the trip to Sacramento. We appreciate it. Your presence here obviously notes to us the significance and the importance of the items that we'll be discussing today. We're going to reach out basically to many of your staff and many of you who have scheduled meetings as necessary, and we will obviously be meeting with a number of different interest groups as we move forward. This issue that we're addressing today, IHSS, is an issue that is of extreme importance. You should know that many of us on the dais, many of us elected officials are familiar with the issue. I've only been in the Assembly 1 year, but I have been engaged and involved with the issue of IHSS probably for the last 30 to 40 years, helping with the early development of one of the programs in San Diego. But more importantly, in the last year, having spent half a day in a home with caregivers. So I became aware of the many challenges, the great opportunities that are there, the love and compassion that's often shown to those who provide the services. So I say that so that you'll know that your concerns don't fall on deaf ear. It's not without some understanding and compassion that I hear the issues as the sub-chair of this budget, and obviously we're going to do as much as we can in the state of California to try to do the right thing. So once again, I thank you all for coming, and we're going to proceed with our items. We'll begin with issue 1, which is the In-Home Supportive Services Program Budget and Program Review. And I think do we have a panel first? Yes. We have a panel first that will be coming forward. I'd like to call the panelists up. I believe that the panelists are Brandy Wolf. Excuse me, we have Mr. Lightbourne first. In his panel, his staff, he's the director, and Eileen Carroll, who's the deputy director of adult programs. We'll also have Kashi Kasarwani, almost got it right, from our Legislative Analyst's Office. Thank you so very much for coming. We're going to hear your presentation first, and then it'll be followed by a panel of interest groups. Thank you very much.
Thank you, Dr. Weber. Will Lightbourne, Director of the Department of Social Services. I'm joined from the department by Pete Chervinka, the Program Deputy for Services, and Eileen Carroll, the Deputy Director for Adult Programs. We will do a walkthrough of the program itself in a few moments, how it's developed and major changes in recent years, as well as the immediate implementation tasks of the Coordinated Care Initiative and the FLSA changes that lie in the year ahead. But I want to just take a few minutes just to frame where we are in context. The IHSS program is the crucial resource that allows more than 450,000 aged, blind, and disabled Medicaid recipients in California to remain safely in their homes. And it is a precious resource. It has been obviously the subject of much funding stress over the years because of its size, but it is something which we have been able to maintain as an entitlement in California, and we have by far the largest program in the country. It's a what's called an optional personal care services under the Medicaid program. And in California, our program is 99% self-directed care. Only a very small number of people are in agency care. Just to put that in context, by contrast, 450,000 recipients in California. Massachusetts, which operates another personal care services option program, is 40,000 people. New York is 80,000 in their personal care services program. And in New York City, all of the recipients are in agency contract care, not self-directed. New Jersey has a personal care services Medicaid program, but it limits the amount of hours any recipient can get under the Medicaid component to 25 hours. In California, by contrast, the limitation is approximately 90 hours per individual. District of Columbia, sizable program, 100% within managed care and agency-managed approach. Not consumer-directed. So for 40 years, we've run the program in California on the fundamental premise of what's referred to as the companionship exemption, that we would be building it around largely people known to the consumer, and in our case, 70% of the providers being relatives. We're one of very few states that allow spouses and parents to be caregivers reimbursed through the program. And we've also sort of attached to it other very small waiver programs that sort of operate in conjunction with it by the same rules. So, for example, some of the very highest hour recipients, some of whom you'll hear from today, who are in the waiver personal care services program through the Department of Health Care Services, there are about 1,300 people in that component, still premised on the same approach, which did not anticipate a change to the companionship exemption rule. For the past 2 years, the administration has been in communication with the federal government over the proposed change to the Fair Labor Standards Act as it would apply to the companionship exemption. Secretary Dooley wrote on 3 occasions to the Department of Labor, to the White House Office of Management and Budget, and we participated in a number of OMB listening sessions along with advocates for the program and disability advocates, making the point that the California program was unique and that a significant change to the caregiver exemption would fundamentally change the trajectory of the program and create unaffordable cost exposures to the state. Despite the communication, the federal administration did not take our concerns did not respond to our concerns, with the exception that, and we do appreciate that they gave a 15-month timeline for implementation. That is not usual in federal rulemaking, and we want to recognize that they took that step. We've continued the dialogue with federal agencies regarding all of the implications and ramifications of the rule and how to implement it, but ultimately and unavoidably, in order to avoid capping services to consumers, our administration has seen no viable alternative to limiting the number of hours each provider can work. We will elaborate on the proposal in detail a bit later, but I want to emphasize that we know even though it does not limit available services to consumers, the limit on providers will create hardships. And although the proposal is designed to protect health and safety of consumers, it is not possible to fully mitigate all of the concerns we foresaw and we predicted to the federal control agencies. And we have had eloquent testimony over the past 2 months as to the reality of what those concerns are. So with that, I would just like to wrap up, ask Ms. Carroll to give you a sort of I think Mr. Cervinka first is going to do sort of the highlights of the structure of the program, and then Ms. Carroll on the immediate implementation steps ahead. And then, of course, we're happy to answer any questions that the committee has now or later. Thanks.
Thank you, Madam Chair, members. Pete Chervink, I'm the Program Deputy Director at the Department of Social Services. The Sergeant, I believe, has handed out an IHSS overview PowerPoint. We do not intend to walk you through all pages of that. I know it's a thick document. Additionally, I don't plan to cover the other handout you received, which is a package of the 3 letters that Director Lightbourne referenced in his remarks a moment ago. We were asked to provide a brief overview of the program. As the director indicated, the program's been in California for over 40 years, and it is a consumer self-directed program. We're one of the few states in the country that in their Medicaid program spends over half of the budget for long-term care and supports in home and community-based care. And IHSS is 95% of that total. The page 3 of the PowerPoint gives you some caseload statistics. The average cost of care in the program is $1,038 per month for an average of 84 hours of care for the consumers. A quarter of our consumers are over the age of 85. 30% are between 65 and 84, and 7% of them are under the age of 21. You have a caseload chart provided for your information as slide number 4, and that just provides the history of some fairly rapid growth in the mid-2000s that largely leveled off but has begun to grow again in the last year and a half. On page 5, we have approximately 377,000 active care providers in the program, taking care of just over 450,000 consumers. 70% of the providers are related to the person that they take care of, and 48% of providers actually live with the person that they take care of. Those numbers don't add to 100 because they're 2 different descriptives of the provider population. Wages for those providers are determined at the local level at each county through collective bargaining, and our average hourly wage and benefit amount for those providers, that's the statewide average number, is $12.35 an hour. And then the overview of the budget is on page 6. In the current fiscal year that we're in now, the budget for the program is $6.1 billion, comprised slightly over half of federal funding, just under $2 billion in state general fund, and just under $1 billion in county contributions. And the budget for next year as proposed is $7.2 billion. That reflects the federal regulatory changes, including travel and wait time and the costs of the administration's proposal. As a final budget note, over 99% of the program receives federal financial participation. We were the first state in the country to implement the Community First Choice option, known as CIFCO, that provided a 56% enhanced FMAP rate for those recipients who meet a skilled nursing facility level of care. And approximately that other 1% of the program is in what we call the residual program, which is a mirror of the rest of it, but does not receive federal financial participation. In the slides that follow from number 8 through number 18, there's a long recitation here of a number of proposals that were enacted in the program. Some of those were enacted and eventually repealed. Others were implemented and have sunset. It's there for your information, and we're happy to answer questions about it, but we don't intend to walk through that unless the committee would like more detail on those things. And at that, I would like to go ahead and turn it over to Eileen Carroll. She's our Deputy Director for the Adult Programs Division. Thank you.
Madam Chair, so moving forward, if you can move to slide 19. This brings us up to the most recent, which is the 2013-2014 activities that have been occurring. April 2013, the CCI Memorandum of Understanding was signed between DHCS and CMS, beginning what will become our dual demonstration project under CCI. Final work is in process. Our department has contracted with Managed Healthcare Plans this year to provide them data and information on the IHSS caseload. Public authorities and the counties have signed MOUs in 2013 with the managed care plans. And again, this is in the 8 CCI counties. Processes are being developed for care coordination teams with the managed health care plans. One of the significant benefits to managed health care and the dual demonstration project. And the universal assessment, the home and community-based universal assessment process began in September of 2013, and we are in process with a very large stakeholder group moving forward to identify how we can work all the home and community-based assessment processes in a way that benefits health outcomes and community outcomes. We don't anticipate that being completed until 2015-16. Finally, the voluntary provider training curriculum, which was put into statute, was developed with stakeholders in May of 2013. In January, on our department's website, we posted the work from that, and there is a very large continuum of voluntary provider training that's been posted, and we are continuing to work with all the stakeholders on how it gets disseminated. On page 20, the administration has worked closely with consumers and their representatives and labor to resolve some of our long-term issues, which resulted in the combining of 3 lawsuits known as Oster 1, 2, and Dominguez. The only reason I'm raising it is this has led to, as of July 1st of 13, an 8% reduction in the program. So prior we had a 3.6, so on July 1st we did 4.4 on top of that. Come July of this year, that will drop 1% down to a 7% reduction. DHCS is in the process of working with CMS to supply something in the fall about a provider assessment that potentially could be used to offset the 7% ongoing reduction. On page 21, as I said, Coordinated Care Initiative is going to be starting to roll out actually next month in San Mateo, San Diego, Riverside, and San Bernardino. We also have the Maintenance of Effort, which began in 2012, that changed the funding within the county process. Previously, they had a 15% share of the total cost in the program. Now under the MOE, that was set in 2011-12. The only increases come to it if wages are changed. Finally, we have the IHSS County Reassessment Performance Data. Currently, statewide, we've seen in 2011, we were at 89% compliant in reassessments. 2012, we reached 90%, and in 2013, the number is at 91%. So which means 91% of the counties are performing reassessments timely. Moving into our future, we start to look at some of what are the basic facts around the Fair Labor Standards Act. So September 17, 2013 was when the new rule was released. And at that point, efforts began to research it and to understand it. Previously, providers were considered exempt, as Will mentioned at the beginning, from the companionship service exemption. However, this changes as we move forward. And January 1st, 2015, we'll be working on a process that would either allow or disallow providers to be paid overtime. Additionally, providers will be entitled to receive compensation for activities spent on other non-work activities, for instance, traveling and wait time. On page 23, the governor's proposal was built upon the concepts, that we are trying to ensure that recipients have available, sustainable, and controllable IHSS services as we move forward into the future, regardless of economic uncertainties that can happen at any time. Our key features include that the providers will be limited to working 40 hours within a work week, and a work week is Sunday through Saturday. Recipients will continue their role as employer within the 40-hour limit per provider, maintaining the choice of providers as well as the responsibilities they've traditionally held for hiring and firing and managing their provider. They will be required, recipients and providers, to complete a workweek agreement that sort of lays out what the proposed hours are on a daily basis, so we can help individuals maintain that 40-hour limitation. Statewide, we're looking at a provider backup system to be implemented in each county to allow recipients not to receive a gap in services if their provider is reaching the 40-hour limit and there are concerns and issues. That's kind of like the thrust of that proposal. As we look into the future, is what we're working on page 24, we are looking into how they implement the FLSA changes, whether they are the ones that are required, which are a significant change to the program for wait time and travel time, or they are part of the governor's proposal. We had a stakeholder work group on Monday this week where we went through the proposals, the FLSA, the governor's proposal, and we had discussions with all the major interested parties, similar to who is here today. We expect to keep moving forward with that process, and we are planning for a stakeholder meeting the week of March 17th to continue to dig in and develop the issues and concerns that we're all hearing, and we want to help create unavoidable issues that could impact individuals. Finally, on page 25, because this is a major programmatic change both in the program and in our systems, we need legislation to be enacted by July 1st of this year so we can be in compliance with January 1st of 2015. And that's regardless of where any of the discussions go, we still have to be compliant on January 1st. Thank you.
Comments?
Yes, thank you, Madam Chair, and good afternoon, members of the committee. My name is Rashi Kesarwani with the Legislative Analyst's Office, and given that the administration has laid out the components of the governor's proposal to respond to the federal labor regulations, I'd like to move into providing you with an overview of our findings and recommendations related to the proposal. First, I want to note that our analysis was conducted prior to the release of trailer bill language that was put out yesterday. We are continuing to evaluate that trailer bill language and are determining whether any aspect of our analysis needs to be updated. On a purely fiscal basis, we find that the governor's proposed overtime restriction is a reasonable starting point for responding to the new federal overtime rule. The agenda does a really great job of laying out the costs on page 5 of restricting overtime versus paying for overtime on an annual basis. And you can see here that it would be significantly higher to pay overtime for all IHSS providers. So there is a significant fiscal benefit to the state as it relates to this proposal. However, we do raise a number of significant policy concerns with the governor's overtime restriction, and we therefore propose potential modifications for legislative consideration. The modifications are intended to balance the goals of achieving some cost avoidance when compared to the paying of overtime for all IHSS providers while mitigating the policy concerns that we raise. We provide 4 criteria that can be used to assess the governor's proposal on fiscal as well as policy grounds, and that can also be used to assess the modifications that I will get into. So to first go over the criteria that we lay out in our analysis, the first criterion is a consideration of the amount of general fund cost incurred for overtime as a result of the proposal. Obviously, under the governor's overtime restriction, minimal overtime costs would be incurred because providers who claim overtime on 2 occasions would be suspended for a period of 1 year. The second criterion is a consideration of the degree of consumer choice provided by the proposal. Under the governor's overtime restriction, one of our primary policy concerns is that recipients who regularly need more than 40 service hours per week would be required to hire an additional provider if they currently receive all of their care from a single provider of their choice. This would be an inconvenience for some recipients, but it could also be a significant challenge for others who are used to receiving their care from their preferred provider. The third criterion is a consideration of the administrative cost and complexity of the proposal. The governor's overtime restriction does require some increased administrative costs and complexity in terms of needing to pair consumers with the right backup provider who can meet their individualized needs. One of our policy concerns is whether the provider backup system will be able to pair all consumers with the right backup provider who can meet those needs. The fourth criterion is the need for additional providers as a result of the proposal. The governor's overtime restriction requires a significant increase in the pool of available IHSS providers. It's uncertain whether a sufficient pool of providers will be available in every county to meet the needs of all recipients who regularly need more than 40 service hours per week. That is another policy concern that we have with the governor's proposal. Generally, we find that the governor's overtime proposal lacks flexibility in terms of its absolute restriction on all overtime and in terms of the suspension of providers who claim overtime on 2 occasions. If the legislature is interested in working within the framework of the governor's overtime restriction, which, as I said, is a reasonable starting point because of the fiscal benefit it provides, the legislature can seek to mitigate some of the policy concerns that we've raised through potential modifications that we provide for legislative consideration. And I want to note that each of these modifications would likely require approval from the Centers for Medicare and Medicaid Services. So moving into those modifications, the first potential modification is a targeted exemption from the overtime restriction for IHSS providers of certain recipients. For example, individuals with developmental disabilities or recipients who live in rural counties who may face challenges in identifying and hiring an additional provider. The second potential modification is a limited allotment of overtime, such as 48 hours annually for providers working for recipients who receive more than 40 service hours per week. This would give providers the flexibility to work some overtime under certain circumstances. The third potential modification is to authorize overtime for an existing provider when a county is unable to provide a recipient with a list of additional providers that they could hire or is unable to supply a backup provider. This modification could ensure that recipients were not forced to forego authorized service hours in the event that there was a lack of availability of providers. The fourth potential modification is to consider a program model that could allow the recipient to become the sole employer of the provider, such as a cash and counseling model that's been used in other states. Under such a model, the recipient would receive an allotment of funds that they could use to purchase personal care hours and potentially permissible goods that make it easier to remain at home. And in cases in which the recipient lives with his or her provider, the recipient under this type of cash and counseling model could potentially be able to claim an exemption from the overtime requirement under federal labor regulations. So in these cases, the recipient could hire their preferred provider for all hours and pay that provider the set wage. We therefore recommend that the legislature request information from the department on the policy merits and trade-offs of this model for delivering personal care services. Finally, we have 2 additional recommendations related to technical implementation issues if the legislature wishes to work within the framework of the governor's overtime proposal. In the interest of time, I will be brief on these 2. The first recommendation relates to the structure of the suspension for providers, and the second recommendation calls for certain reporting requirements of DSS to the legislature. Thank you.
Okay. Anyone else on the panel? Any other comments? Any comments from the dais? Before we do that, actually, we think we should call roll, so while we have a quorum.
Weber,
Here.
Chesbro, Dickinson, Grove, Mansour.
Okay, good. Yes.
Thank you, Madam Chair. I have a few questions, and I'm just curious, and I don't know if Ms. Carroll, Mr. Lightburn, or the LAO is going to be able to answer them. So, whoever can answer them. I don't mean that neither of you can. I just don't know which one of you can, if that makes sense. So, how many providers do we have out there that exceed the 160 to the max 283 hours available for care? Or how many consumers? I guess
Right,
the question is consumers.
It's approximately 49,000 consumers in the program today exceed the 160 hours a month target number.
So, based on what the governor's proposing, 49,000 consumers in the state of California are going to be affected by this overtime issue, the 160 to the 283.
A significant subset of the 49,000, in that some of the 49,000 already have multiple providers.
Oh, okay.
And the likelihood is that they would be able to operate within the boundaries of the proposal. Those who have a single provider would then have to engage a second provider or multiple providers in order to have their full hours served.